Dr. Iain McGregor completed his undergraduate degree in experimental psychology at the University of Oxford and gained his PhD in psychology at the University of Sydney. He is currently a Principal Research Fellow from the NHMRC, a Professor of Psychopharmacology and Academic Director of the Lambert Initiative for Cannabinoid Therapeutics. Is that okay?
That's just
Please
perfect.
welcome the
Thank you very
incredible,
much.
amazing Iain McGregor.
Imagine preparing all these slides and not getting the opportunity to speak, eh? It would have been terrible. I'm here to give you a brief update of some of the research that's been going on at the Lambert Initiative, and coming to the UIC conference, it always causes me to reflect upon how this all started and to rewind back to 2014 at the inaugural UIC Symposium when I met Lucy for the first time, and Mike Baird opened that up, and we travelled up, Dave Alsop, Nick Lantzeris and Tom Arkell, a very young-looking Tom Arkell there to Tamworth for that wonderful event. And the conference dinner, I think, was at the Tamworth Racecourse. and at that conference dinner, we met Michael Lambert, and we got chatting to him, and the rest is history. Basically, he had very wealthy parents. He had a daughter with pediatric epilepsy who was very well treated by cannabinoids, and the Lambert family gave an extremely generous gift to the University of Sydney to set up this research enterprise back in 2015. And there's Lucy at the ceremony where we celebrated the beginnings of the Lambert Initiative. And I'd like to say it's just been a heap of fun for the past 7 years, and I've had non-stop entertainment, but my role is mostly problem solving with a little bit of creativity as well. But we've been reasonably productive and had a good time. Unfortunately, we lost Dave Alsop along the way, a dear friend of ours. He was right there at the beginning of the Lambert Initiative, and he died way too young of esophageal cancer. And it's good to take a minute to reflect on Dave, as well as Dan as well, who I met at that first UIC. And Dave, I think, would have been thrilled to see this graph. He loved numbers, and he died in 2018. And you can see by the time we got into the middle of 2019, there'd only been 9,500 approvals for medicinal cannabis in Australia. When you fast forward to 2022, today, if you look in February of 2022, we've got 9,761 approvals in that 1 month. So the first 3 years of the program, basically we only had the same number of approvals as we had in that one recent month. So Dave would be very pleased about the progress that I think we're all seeing at 2022 UIC. If you want to learn what the Lambert's up to, we've got a fully featured website, and we spread a lot of information about our trials and other interesting things to do with cannabis and cannabinoids on our Twitter feed as well. So please subscribe to that. And we do quite a lot of preclinical research that I'm not really going to talk about today, but we're very much engaged in drug discovery around cannabinoids. We have a library of more than 900 proprietary molecules, a few of them IP protected, largely thanks to the work of Dr. Sam Bannister, who up until recently was our lead medicinal chemist. We screen a lot of these compounds to receptor and target. We do computational and actual high throughput screening, and we run a lot of cellular and animal models of disease, particularly in epilepsy, but also in cancer, inflammatory conditions, and a whole host of other things. We've moved quite recently towards zebrafish. We've got zebrafish that recapitulate the same genetic abnormality that you get in Dravet syndrome, which is a type of epilepsy that Caitlin Lambert suffers from. And that enables us to do very rapid, high throughput screening of compounds in that type of epilepsy. We publish a heap of preclinical papers, a lot of them quite highly technical, and our preclinical programs led mostly by Jonathan Arnold, who couldn't be here for this conference, but sends his best wishes to everyone that he knows here. On the other end of the spectrum, we do a lot of surveys and a lot of clinical trials as well. We track prescription trends. We had a paper just out last week, which was analysing in some detail the trends of medicinal cannabis prescribing in Australia over the first 5 years of operation of the program. It's not a bad read, and it's a free download from Frontiers in Pharmacology. led by Elizabeth Cairns and Sarah McPhail. And as we all know, about 60% of these approvals are for chronic pain, but we see this large increase in prescribing for anxiety as well, which is very interesting from a scientific and medical perspective, because a lot of the evidence around THC and anxiety is not there yet. Insomnia is the third most common condition, and also cancer and related symptoms too. And then a whole host of other conditions as well. And so these trends are tracked and presented and discussed in that paper that we published last week. One of the really interesting things is these mental health conditions and the sort of exponential rise in prescribing for not only anxiety, but also PTSD, depression, and ADHD. And this is kind of almost an evidence-free zone. If you look at medicinal cannabis and depression, we don't really have much evidence at all, but prescribing continues nonetheless. And in a sense, we've got this odd situation where clinical trials have to catch up with clinical practice, which is really quite interesting. Rhys Cohen, I think, presented this very interesting trend, which is, in the early days of SASB, it was largely oils, and now we see, as John Skerritt mentioned yesterday, a massive increase in the use of flower products to the point where they're kind of meeting the level of oil prescriptions, and that's the same data but shown in a nice waterfall graph. What else do we see? Increased prescribing in 18 to 30-year-olds. Look at that blue line. That's a proportion of scripts for youngsters. And in the early days, it was older age groups that tended to get prescriptions. Now we're seeing the rise of 18 to 30-year-old males getting flower products for mental health conditions. It's a very interesting change over the last 3 or 4 years in the demographic being serviced. And as we all know, Queensland seems to be a great place to get a medicinal cannabis prescription. A lot of the scripts are coming out of this part of the world, and I think John challenged us yesterday to come up with a PhD that explains why that's the case. So anyone that wants to be supervised for a PhD in that topic, please send me an email. I'd be very interested to interrogate these trends. We do a lot of work with patient surveys. We've done surveys of patients with inflammatory bowel disease. We've done surveys of driving and medicinal cannabis patients. And every 2 years, we run what's called the CAMS survey, which looks at both illicit and prescription users of medicinal cannabis in the Australian community. And we've done CAMS 16, CAMS 18, and we've got the data for CAMS 20 involving 1,600 Australian patients. 62% of them are using only illicit cannabis to self-medicate a condition. 13% were using prescription products. And now we've got this new category that's very interesting, which is what we call dual users. So these are people that have a prescription for a medicinal cannabis product, but also like to mix it up with a bit of illicit products as well. So that's the first CAMS survey where we've seen this many dual users, and they're interesting demographic. Most commonly treated, chronic pain. And the prescribed users and dual users tend to be older, tend to be female, tend to be inexperienced with cannabis, particularly the prescription-only users and using for pain. If we compare the illicit users to the prescribed and dual users, you find that the illicit users are much more likely to smoke their cannabis. I guess that's no big surprise, because when you get prescription flower product, you're told to vaporize and not smoke. So there's a bit of vaping with the prescribed cannabis. Overwhelmingly in the CAMS survey, people say that cannabis really works. So 90% basically of the illicit users say that the cannabis, they feel very much better, or at least a little better with the cannabis product they've used, and same with prescription as well. So very interesting, 90% of patients saying that cannabis is great for their condition, whereas the clinical trial evidence often isn't there to affirm that it should be working for that condition. Current access system, both prescribed and illicit users complain a bit about the difficulty in accessing, particularly the illicit users, but even the prescribed users strongly disagree with the assertion that accessing medicinal cannabis is straightforward. So there's still a lot of work to be done to make access easier in the Australian community. Just thought I'd mention this trial, which we hope to start next month, if all goes well. We're just waiting for permissions from ACT Health. We're going to recruit 200 ACT cannabis cultivators. Now, you may be aware that it's legal to cultivate a certain amount of cannabis in the ACT. So we thought this is a great opportunity to look at these cultivators and see if they're doing it for medical or non-medical reasons or both. So we're going to do that. We're going to give them a survey, but we're also going to take a little bit of their cannabis as well back to the labs at the Lambert initiative. And we're going to look at what homegrown cannabis in the ACT looks like, what the cannabinoid content is, and we're also going to test for molds, pesticides, toxins, heavy metals, that kind of thing, just to affirm the safety of the product too. And I hope if we're able to show that the cannabis they're growing is good, if we can show that it's beneficial to their well-being and health, then what's happening in the ACT may spread to other states and territories, hopefully in the future. So look out for a launch, hopefully next month. We're still wrangling a bit with ACT Health and the Solicitor General of the ACT to get the permission to remove the cannabis and bring it back to our labs. But I think we'll get there. We've got an opinion from the DPP that everything should be fine. What about prescribers? Well, as you know, GPs are doing the vast majority of prescribing in Australia, and we've got a new survey, as yet unpublished, where we went and found more than 500 GPs and asked them what they thought about medicinal cannabis. It's quite interesting. This was led by Zita Bawa at the Lambert initiative, and about 20% of these 500 odd GPs were currently prescribing medicinal cannabis. And what we found, if we asked them, do you support the use of medicinal cannabis for condition X? Basically, the more serious the condition, the more supportive they were of medicinal cannabis. So amongst this cohort, whether they were prescribers or not, there was overwhelmingly approval for the use of medicinal cannabis in cancer pain, in palliative care, in intractable epilepsy, et cetera. Where they got more cautious was with these very mental health conditions where we're seeing prescribing go through the roof. So when it comes to depression in particular, there's a lot of skepticism amongst the GPs, and even insomnia and anxiety, where we're seeing large amounts of prescribing. If you ask both non-prescribers and prescribers, there's a lot of reticence around prescribing for these mental health conditions, often lacking evidence, I guess, and that may be what's driving their skepticism. They had some interesting attitudes. One was that they don't like the idea of pharmacists being able to give low-dose CBD out to the community. It's probably a bit of a pitch battle. You know, that's our turf. You don't get to give out CBD. That's what GPs do. So we were quite interested to find that. They overwhelmingly want more education and training, and we've done a pharmacist survey, which I don't have time to report today, and it's exactly the same with the pharmacists. They feel there's a knowledge gap in their profession. They all want good quality training in this area, and they're also very concerned, the GPs, about driving and product cost as well. This comes from their patients. They are hearing all the time that driving is an issue, and we'll discuss that obviously in the panel in a minute. And this is probably my favorite one from the GP survey. You asked them to say, well, is medicinal cannabis more hazardous than these drugs that you commonly prescribe? And overwhelmingly, they think that medicinal cannabis is safer than opioids, safer than benzos, safer than chemotherapy drugs, even antipsychotics and antidepressants, and kind of on a par with statins. So they have quite a realistic appraisal of the risk of medicinal cannabis, and that's interesting to know. We've been working a lot on educational resources for GPs. We published an article with Tamara Nation, who spoke yesterday at this conference, on how to prescribe back in 2020. We've had a series of articles in the Australian Journal of General Practice, which are free downloads on pain and driving. There's a very good one by Anthony Herbert on palliative care, and Jonathan did an excellent one on adverse effects. So we do our bit as best we can to try and educate GPs who have this thirst for knowledge. What about our clinical trial activity? Well, we've got a wide range of partnerships with different medicinal cannabis companies, different universities and institutes all over the world, rolling out all sorts of clinical trials, and it keeps us very busy indeed. A couple of trials that we've recently concluded that are quite notable. One is the CanSleep study led by Anastasia Sureyev, and that was looking at a 20-to-1 cannabis oil in the treatment of primary insomnia, but also did some really advanced EEG to look at the effects of cannabinoids on sleep architecture. And I'd love to tell you the results. I do know the results, but they're basically embargoed until we go to Ireland next month and present them at the ICRS meeting. But they're kind of interesting. Yeah, we found some cool stuff. So look out for that next month. It'll probably be in the media. We just finished a trial in Tourette's syndrome. People with tics, with Phil Mosley up in Brisbane, with CBD THC 1-to-1 product, 20 milligrams of CBD and 20 milligrams of THC. And we're just crunching the numbers on that one at the moment, so I can't share. I don't know whether it worked or not. I'm desperate to know, but we don't yet have the numbers. Couple of trials I can tell you the results of, which were quite interesting. This is a little pilot trial we just finished down in Melbourne with hand osteoarthritis, and we worked with a company called Evetro to put CBD in a 4% gel that people with hand osteoarthritis rubbed onto the afflicted hand. And we used a squidgy ball that was connected to a smartphone app in the cloud to gather data on their grip strength, which is often deficient in people with hand osteoarthritis, and also to get pain ratings as well. And this is what happened. Their grip improved significantly over the 4 weeks of treatment with the gel, and their pain ratings went way down as well. So maybe CBD we should be applying topically rather than orally in the treatment of certain pain conditions. The post-dosage period was the week at the end where we withdrew the gel, and it was interesting that the grip strength was impaired and the pain returned when the gel was taken out. So this is enough for us to go into a larger phase 2 trial, which will be placebo controlled. So interesting results there. We ran this study quite a long time ago. It's just about to be published in the Journal of Clinical Psychiatry. And these were young people with really severe anxiety disorders that hadn't responded to conventional treatment. They were really the worst of the worst in terms of treatment resistance. And we gave them an ascending dose of CBD from 200 all the way up to 800 milligrams over 12 weeks, and got a really remarkable therapeutic response in these young people. Look at the ratings, both clinician ratings and self-ratings of anxiety were highly significantly reduced over the 12 weeks of treatment with these scales. So that's enough to encourage us to do a larger placebo-controlled trial again, but it also, we saw effects much more around about 400 or 800 milligrams than with the lower doses that we used in the earlier weeks of the trial. And that raises the interesting question, are low doses of CBD going to be enough? I mean, it's pretty clear in the CAPS trial that it was 400 where stuff started to happen, and particularly 800 is when we saw a huge therapeutic response. And if you review the literature, as we have done at the Lambert Initiative, there's really not much for CBD under 300 milligrams. I know we have a lot of S3 trials underway now in Australia, and I really hope they succeed. Some have fancy formulations that might improve bioavailability, but at the moment, the literature is telling us that you really have to be up about 400 for good stuff to happen. There's a whole ton of clinical trials that are underway at the moment. I'll just flag a couple of them. There's a very interesting pediatric palliative care trial we're involved in up at the Queensland Children's Hospital. These are children with as young as 1 or 2 years old who have severe cancer, who are on the way out, and we're going to look at whether THC, CBD, or CBD by itself can relieve some of their distress and pain. We've got a trial of CBD in spinal cord injury, neuropathic pain. We've got one in anorexia nervosa. We're doing a trial of CBN that Diddy Mary mentioned yesterday, a possible sedative or a useful cannabinoid for insomnia. And Isabel Lavender over here in the Lambert Initiative is planning a trial of CBN in primary insomnia. We're using VR to look at situational anxiety with a CBD wafer. And we've got a couple of schizophrenia trials with CBD, including one with people who've got the most severe schizophrenia, what's called clozapine-resistant schizophrenia. These people are very, very difficult to treat and often have chronic long-term disability and illness. So we're going to see whether adjunctive high-dose CBD is useful in that population. And also for a bit of fun, we're doing a little bit of work on sports concussion. We've got the BUMP trial run by Nathan DeLang, and we bought this lovely contraption that fires soccer balls at people's heads. You too, if you've got a couple of $1,000 spare, can buy one of these, and it launches soccer balls at great velocity at these soccer players' heads. And what we're doing is taking them into a brain scanner after they've headed the ball 20 times to look for signs of neural impairment and the presence of inflammatory markers, with the idea that we'll intervene with cannabinoids to see if we can prevent sports concussive injury with cannabinoids. So we like to have a bit of fun with our science whenever it's possible. Just to close up and to segue into Tom's talk, we've been doing a huge amount of research on driving. 7 years ago when I first met Lucy, I never thought I'd end up being a driving researcher, but it's such an important thing for patients, the whole issue of cannabis and driving. We couldn't help but get involved in this area. And the key issue is that a prescription from a doctor for medicinal cannabis doesn't give you any legal exemption, no legal defense around roadside drug testing and conviction if THC's found within your system. Whereas if you've got a prescription for benzos or opioids, as long as you don't feel impaired or are impaired, then you're good to drive. So there's very clearly a double standard, where science is telling us that cannabis impairment is sort of equivalent to blood alcohol concentration of 0.02 to 0.05, where you can legally drive. So there's a bit of a double standard there, which I think is quite concerning. A couple of important papers done by Danielle McCartney, reassuring for people on CBD-only products. This one's coming out in the next couple of weeks, just to show that CBD, even at doses as high as 1,500 milligrams, produces no impairment of cognitive function or driving ability in a simulator trial. So very reassuring for people on high doses of CBD, and a great study, placebo-controlled, proper RCT. The other thing that's reassuring for people on CBD-dominant products is this study that Danielle also did, which showed that if you're on high doses of oral CBD, you're not going to give a positive drug test using the current technologies that police in Australia use. So you're basically good to go. There's no cross-reactivity between THC and CBD in these tests. Danielle also did this really heroic study, and the question we're hearing all the time from patients is, how long should I wait before I drive to be safe? If I take a THC product, do I wait 1 hour? Do I wait 3 hours? Do I wait 10 hours? Should I wait until the next day, or should I not drive at all? And so Danielle found 80 studies and crunched them into this mathematical model that describes duration of impairment in people who are occasional cannabis users. If you're a daily cannabis user, it's actually quite hard to show impairment. So these graphs correspond to occasional users, and she showed that basically there's a window of impairment that lasts typically about 3 or 4 hours, but up to 10 hours if you use really high oral doses of THC. And that's described in this paper, and there's a very, very nice calculator in Excel where you can work out whether you're likely to be impaired or not at a given dose of THC. And that's been kind of echoed all around the world. That's a great bit of work. And there's also a new paper that Danielle's done looking at day after impairment. So I was involved in a legal case in Toronto where the transit workers were taking on their employers, and the issue was, are you good to go to work? Are you safe in work if you're using THC for insomnia at night? And so again, Danielle crunched all the available information on day after impairment, and she could only find 12 out of 345 tests that had been done that actually showed impairment. So the vast majority of tests that have looked at next day function in cannabis users have found no impairment whatsoever. And the ones that showed impairment tend to be almost as old as I am. They're old studies that often involve not very convincing experimental designs, not very good technologies. So it's a really important issue, and at the moment cannabis looks pretty good the day after consumption, which is particularly important for people using THC for insomnia. So thank you very much for your attention. Pleasure to be here, and look forward to the panel in a wee minute after Tom's talk.